very good afternoon to all of you. And on behalf of National Neonatology Forum, IANN, and WHOCC AIIMS, we are more than happy to welcome you all to this fourth live Nurses E-Module session. Myself, Dr. Anu, and unfortunately, Sir could not join us today, Professor Deorari. So we have Dr. Pratima on my right. Then the other faculty for the current fourth week on developmental supportive care and pain, we could manage to get two faculty in person for you. So Dr. Suman is again on my left, and we have Chitra who's on Pratima's one side, and Dr. Pankaj Mohanty from AIIMS Bhubaneswar, and Dr. Purva Goya from GMC Bhopal have joined us live. We would also like to thank the other faculty, Dr. Tanushri, who could not join us for this session, Dr. Anita Yadav from Safdarjung, and finally, Ms. Madhu from a nursing tutor from the College of Nursing at Safdarjung and DMMC Hospital. So, heartfelt thanks to all the faculty who contributed to this session, and thank you to all the participants also who participated in live and interactive discussions. And here we meet for the fourth session, in which we shall request Dr. Purva and Dr. Pankaj to summarize some key learning points. And the chat forum is open till 12:30. So you're seeing this chat on the YouTube right-hand side. So please type in your questions relevant to the current topic, that is relevant to developmental supportive care and pain management. And we shall take the questions as and when they pour till 12:30. By the meantime, I would request now Dr. Purva, Associate Professor of Pediatrics at GMC Bhopal, to start with her presentation on summarizing the key points in developmental supportive care. Dr. Purva, over to you, please.
Thank you so much, Dr. Anu. And now I'll be sharing my slide. And I would just like to thank Dr. Deorari sir and Dr. Pratima for giving us all this opportunity. I hope my screen is visible. Yeah, thank you. Okay. I done it. Okay. So now I'll be summarizing the development supportive care, the week which we are doing it, and what are the objectives of this week were that we had just introduced the concept and the importance of developmentally supportive care and pain management. And we have also talked and how to implement the developmentally supportive care in the unit, and how to recognize pain and use various methods to prevent or minimize pain. And also we will be touching on to the improving and monitoring practices and outcomes related to developmentally supportive care, and how can we use certain quality improvement methods in the local context related to developmentally supportive care. So these are the 5 core components of developmentally supportive care. The 5 core components are pain protection, the protected sleep, the developmentally supportive activities of daily life, the family-centered care, and the healing environment. So these are the 5 core components. Then the key points of our discussions and the modules which we have shared were that developmentally supportive care is a continuous process and it's not an end. And it should start with the birth of the infant. And this care, that is the developmentally supportive care, should be individualized. That is, it should be based on the cues of the particular baby rather than protocolized. And the developmentally supportive care, what is the most important thing of developmentally supportive care is that it reduces stress and it promotes growth. Neonatal census, what we are doing in the developmentally supportive care is that we are nourishing and nurturing the neonatal senses. The tactile vestibular sense develops first, then the gustatory, olfactory, and then the visual auditory. So we have to stimulate them and we have to nurture them as per their sequence. We will be doing as the sequence of the senses, and then it will be important. So the tactile vestibular sense, we will be looking after the positioning of the baby, the three positions which are important, like the nesting, the swaddling, and the containment, about which we have talked during the week. And these pictures tell us this is nesting, this is swaddling, and this is containment. All these three positions will also lead to decrease in the pain sensation perceived by the baby. So these three positions are also be done while doing some painful procedure. Then gustatory and olfactory, we have to see that feeding could be a stressful procedure for a baby. So try to swaddle the baby during the breastfeeding or katori spoon feeding, or do KMC nesting during the tube feeding. And we have to pay attention towards the signs of stress during feeding. In this picture, you can see the arms are dangling. So this is not a right position. Here you can see the baby is drooling some feeds, and here we can see also the baby is showing some signs of stress. So all these things we have to take into consideration while feeding the baby. Vision and auditory, environmental and behavioral modification to reduce noise in the units is very important. For that, we first have to, the things which we always look and bother to us is the alarms of the different machines, like the ventilators and the monitors. So we have to attend them promptly and adjust their noises so that the alarms don't ring at a very high sound. And the last developing sense is the vision, and which has to be nurtured very nicely, and we have to avoid bright light because it also leads to sleep deprivation in the baby. So the 5 components, like we have seen, the protected sleep, the family-centered care. Here, in protected sleep also, the important thing is nesting, KMC, and cluster care is important to keep a newborn baby or a newborn premature baby a protected sleep. And here, what we can also do is that we can do small QI projects relating to clustering care also can be done, so that we will be able to see how much we are implementing this kind of care in our units. Family-centered care means the involvement of the family in the care of the baby. Here we will counsel and empower the whole family, and also we will support them during the critical times. The activities of daily living, that is massaging the baby, feeding the baby, skin care, and diaper changing. Here these activities should be done along with the family members, and they should be made aware of the developmentally supportive care during these activities of daily life. And the other thing is the healing environment. The healing environment of the NICU or the SNCU can be made by adjusting certain things like dimming the lights, maintaining the circadian rhythm, and allowing the baby and allowing the mother to look at the baby's face. And also we should be very careful to decrease the noise in our units. Like we should not drag the chairs, we should not shout across the unit, and we should also facilitate smooth transition. That means if we are shifting the baby from one place to another, or we are taking the baby to some other place for some procedure, or the baby is shifted to some other unit, then we should be holding the baby properly and the transitions from one place to another should be very smooth. So what we say is the KMC is the best way to provide the holistic developmentally supportive care, because while a mother is doing the KMC, the visual sense is stimulated very nicely, because the mother and the baby will be looking at each other. Then the olfactory sense is also stimulated by the smell of the mother and the smell of the breast milk. Gustatory sense is also stimulated while the mother will be breastfeeding the baby. Auditory sense is also stimulated while the baby listens to the heartbeat of the mother, and also if the mother is singing a low, nice, what do we say, a lori. A tactile stimulation is done also by the holding the baby by the mother and also through the touch of the mother during the skin to skin contact. And the vestibular part is also taken care of while the baby is positioned in the KMC position. So these are the all the six senses which are being nourished by the KMC. So KMC is the best way to provide developmentally supportive care. So thank you from my side and over to Dr. Anu.
Yeah. So thank you so much, Dr. Purva, for highlighting and summarizing the key points. We have some questions coming up in the chat, and we'll take them after Dr. Pankaj summarizes the concerns of pain. So, Dr. Pankaj,
Okay.
you may summarize the learning points from pain management in the NICU, and we are making you the presenter now. Over to you, Dr. Pankaj. Dr. Pankaj, can you share your screen? So till that time, we have one question coming up on the chat, and the question I will ask Dr. Tanu, are you around? Dr. Tanushri? No problem. So I can ask Dr. Pratima. Dr. Pratima, yes. Tanu, are you around? So I can ask Dr. Pratima in the meanwhile. Dr. Pratima, there is a question which has come up in the chat, and the question is by Jaya, and she's asking us that how will you grossly come to know whether the baby is actually showing stress signs or the baby is showing a possibility of a suspected seizure. So one or two, three key points as a nurse, bedside nurse, which a nurse should know that yes, these are stress signs and this looks classically like an abnormal movement or a seizure. Yes, over to you, Dr. Pratima.
Seizure or a true seizure or an abnormal movement actually will be associated with autonomic changes. And you're right, Jaya, that autonomic changes, as we discussed in our chatting also, they are associated with stress also. So another differentiating point which can be there is stimulus sensitivity. Okay, if the baby is in stress and you contain or you touch the baby, he will be calmed down or pacified. However, in seizures, the abnormal movements would be continuous because they are originating from the central nervous system. So that is one way from which we can distinguish basically stress sign from seizures. Definite distinguishing.
So,
Dr. Anu? Yeah.
the seizure, actually, thank you, Pratima, for that. And the seizure will be immediate to begin with, and they would not be restrained by comforting. So, they would still persist even once you hold the baby. While if there is a stress sign, when you calm the baby, swaddle the baby, comfort the baby, immediately you will see a response. And stress sign would be slow, gradual. Seizure would be an immediate, jerky kind of movement. So with experience, you will learn this, that yes, this is a stress sign classically, and this looks like a seizure, an abnormal movement. And there would be other signs, abnormal consciousness. There would be a setting. This baby did not cry at birth, or the mother suddenly brings in the baby, that baby has an abnormal movement, or baby is suddenly lethargic. So the clinical spectrum of both these things will be very different when you actually see a baby having a possibility of seizure vis-a-vis a baby who's otherwise comfortable and is just yawning or putting up the hands in a W position. So those are stress signs that you classically observe. Yes. So Dr. Pankaj?
Yeah.
Yes.
Am I audible, madam?
Yes, you're audible,
Yeah.
and your slides are also visible. So over to you for summarizing pain management. Yeah.
Thank you. Thank you, Dr. Anu, Dr. Pratima, for giving me this opportunity. So I'll be summarizing developmental supportive care and pain management, which have been taught in actually continuing the module 4 in week 4. So sometimes we do not care for the understanding of the language what the baby tells to us. Maybe we do not pay attention to them. See, one baby is telling, I'm sleeping, please don't disturb me. And another baby is telling, I'm already in stress, please do not increase my stress. So something we should understand their language sometimes because they do not speak to us. But relief of human suffering, pain, and discomfort is the most important goal of all healthcare providers, be it a neonatologist, a pediatrician, be it an adult medicine people. Everybody is trying to decrease pain and discomfort. That's what we want to do for our neonates also. So the management of the pain and stress, my objective and goal will be how to recognize and assess pain in neonates, how to prevent and reduce pain, use non-pharmacological measures to reduce pain, and ultimately our goal will be to make our NICU a painless environment. So this is the overview. What is pain? Actually, you know, it's an unpleasant sensory and emotional experience associated with an actual or potential tissue damage. Now, as in our experience and study has also been done, neonates in between 20 to 42 weeks experience an average of 15 painful procedures daily. It may be even more if the baby is more premature according to the clinical scenario. So that's actually harsh. And also by the physiology, we know this that there is immature descending inhibitory pathway in the preterm, so they suffer more pain than we perceive them. They actually give us signs we do not recognize them. This leads to impairment of the brain development, sensory motor disintegration, and ultimately altered neurodevelopment. So types of pain in the neonates actually is taught in the module. So I'll going little fast. Acute pain and chronic pain. Now there will be mild, moderate, and severe. But my idea to tell you that something which you do on the neonates like dressing change, this also causes moderate pain, mind you. So this actually has been done very, very frequently. And nevertheless, heel pricking, venipuncture for any reason, physical examination. See, we do physical examination, but we always tell our nursing staff or student don't to touch the baby very frequently because physical examination can also cause mild pain. There are arterial puncture, feeding tube insertion also. That is a procedure which is generally being followed, and day in and day out, that also causes mild pain. So these are the few things which can cause mild, moderate, and severe pain. Severe pain will be any surgical procedure. ROP examination, chest physiotherapy, central line ET suction causes moderate pain. Chronic pain we see in the baby with having necrotizing enterocolitis, any bone and joint infection like osteomyelitis, brain infection, and if you are ventilating a baby. So these causes the baby to suffer chronic pain. Now, how neonates communicates pain? Suppose a baby is having pain, how will recognize them? Now, there are three signs, as is had been depicted in the module. There are three signs you can tell: behavioral features, motor features, physiological or autonomic signs that baby actually give us, and we should recognize in them. Behavioral signs may include facial expression and like brow bulge and eye tightly closed. This picture I remember this is in the module. So nasolabial fold will be deep pain, baby's mouth will be open, maybe squarish shaped, and baby will have some motor manifestation also. There will be stiffening, arching of the back and limbs, hyperextension of the limbs, arching of the body, jerky movements, fingers play, foot play. These are some stress signs that already told by Dr. Purba. I think I'm not going to in detail. Sitting in air is also a sign of stress, but we should recognize it. And there are some other signs for physiologic and autonomic signs. As we know, the normal heart rate and respiration, though we always do our vital charting, we should recognize the change in heart rate, change in respiratory rate, change in type of respiration. Yawning, sometimes we feel in our time, also we feel yawning is a good sign, but yawning is also a stress sign. Mydriasis, startles, tremors, pallor, and flushing, these are all stress signs, and when the baby will be pain, they will be giving us the clues to recognize. Now, how to assessment pain? There are different tools available, but one tool which we have discussed, I think it is the PIPP, Premature Infant Pain Profile, that contains actually there are 7 criteria in it. We include gestational age, behavioral state according to baby is quiet, asleep, or active, and change in heart rate, change in oxygen saturation. Facial expression has 3 components in it. One is brow bulge, eye squeeze, and nasolabial furrow. So actually there are 7 components, and the score is given from 0 to 3. So maximum score will be 21 and minimum will be 0. So higher score will have greater pain. So less than 5 have no pain, 5 to 10 moderate pain, and more than 10 severe pain. And we should also understand how to recognize, because when baby is in quiet state, we should take the baseline heart rate and change and respiration and SpO2 we should see. Then when we are doing something, and in procedure we can assess the pain for 30 seconds, and we have to score them, and according to that we have to behave, or we have to treat it or manage it. So there are other tools which are NIPS, neonatal infantile pain profile, and neonatal facial coding. There are things are there, but we should be very much well conversant to take PIPP into our module, so that it is incorporated in our NICU in day 1 and day out. So how to reduce pain? There are different measures we should take. One is the general measures. Non-pharmacological measures will be discussing details into it. Pharmacology, I am not going to it because it is not in the module. So for the completion, say, I'll be telling something, but this we will be discussing on general module. So general measures will be first to prevent and prevent. What to prevent? We should prevent bright light exposure to the neonate should be the bright light should be avoided so that neonate will not be exposed to directly to the bright light. And we know we have a lux meter in place. We can download the app in your mobile, check lux, how much light is actually falling on the baby. The recommended range is 10 to 600 lux. Noise, as I have already discussed in our module, we have lots of questions on it, we have clarified, should be less than 45 decibel, but should not be more than 55 to 60 anytime. We should use cycling light. Sometimes it is not available in different SNSU. At least we have to dim the light in the night time. And the procedure, when you are doing procedure, you should focus it in a particular direction so that the site of interest should be focused, not the entire baby should be exposed to the bright light, and avoid direct light always. The direct light, we know the phototherapy care and all. So direct light should not be fall into baby's eye. Then limit the number of painful procedures handling. So we have to limit. Suppose we have a morning round, we have discussed these things to be done. We have to cluster it. We have to limit whatever is required only we'll do. We'll not do anything which is not required. And other thing like we have already, Madam Purva has already discussed, not going to it. So swaddling the baby, facilitated talking, distraction measure, talking. So mother's voice is actually a very, very good soothing for the baby. You can have music, but there are limited evidence. We have Indian evidence on Indian classical music, so that can be played in the baby's ears slowly, so that baby will be calm. Bundling of the investigation has already been told. So barrier nursing in with addition to the bundling of the investigations and nursing interventions should be done. Tactile stimulation, stroking, caressing, and massaging the baby to be done for making the baby calm and quiet, so that the will go to an painless NICU environment. We can create it. So this is a very important slide to depict that what we can do, non-pharmacological measures we can take to allay the baby's pain and stress. So these are all actually environmental and behavioral intervention. First is when I have a slide to depict that how to go away when you have a painful procedure to initiate. But first, when the baby is stable, hemodynamically stable, and baby is the stable term or preterm, we try to with the baby breastfeeding. Then best is to breastfeed the baby, or you can do at least non-nutritive sucking. Breastfeeding, if it is not available, then you can give some KSF feeding through breast milk, what mother will be providing. So that is very, very important. It lessens the cry, less increase in heart rate, and there is less facial scoring score. And also, what you can do is you can provide KMC before that if the baby is stable and not stable also. Sometimes not stable means hemodynamically should be stable. But sometimes when the baby is on ventilator, sometimes baby is on CPAP also, we provide like this, a picture from our unit. So mother is giving KMC, even the baby is on CPAP. And other thing is we can provide non-nutritive sucking through the finger or through the empty breast. So mother can express the milk, and after that when the breast will be empty, the baby can suck on the empty breast. So that is also lessens the pain. It has favorable effect on autonomic and motor signs. And the last but not the least is the drug that we give sucrose, 24% or 25% dextrose. So that we'll be discussing in next slide. So it causes also less behavioral cues of pain and less autonomic changes. So these are the things that we can do before we start a painful procedure. So just telling about sucrose analgesia. This is it is actually being administered when we plan for a short procedure like venipuncture and heel prick, maybe in ROP screening. Concentration is 20. Sorry.
More, yeah, we can just compile because there are a few questions to be answered.
So exactly. So time should be 2 to 3 minutes. Analgesia effect 5 to 8 minutes. We can have an added effect if we combine with other measures. So the dose is 0.5 to 1 ml according to this is given in module. So this is a practical algorithm. If you plan for venesection, heel lancing, secure IV line, we can plan for breastfeeding, NNS or skin to skin contact. Then all the facilitated talking and sucrose. Assess the pain score, please, what I have told, and act accordingly. So take home message will be neonate do suffer from pain, stress in NICU. We need to identify, assess severity of the pain. Simple measures like breastfeeding, NNS containment, allay pain and stress. Oral sucrose is helpful, should be given in conjunction with general measures. So let's make our NICU a painless environment. Thank you.
So much. Thank you so much, Dr. Pankaj. And I think continuation with your talk, we have a question coming up, and this question has been asked that can we combine, you talked about pharmacological and non-pharmacological measures, Dr. Pankaj. हम इनको combine कर सकते हैं? Can we combine them for, meaning when you want to treat pain or you want to address the issue of pain, can you combine both pharmacological and non-pharmacological measures?
Yeah, madam. We can combine them for optimum effect. As we combine with general measures with non-pharmacology, we can combine them, but we have to assess pain first, and if we see the baby is having severe pain, then actually we can combine.
So yes, the answer is absolutely true. Like classically, when we do ROP screening, you give a non-pharmacological measure like a sucrose or a dextrose swab, and then you also put some local anesthetic and you give fentanyl infusion when you're doing laser. So you can combine pharmacological and non-pharmacological measures. Thank you so much, Dr. Pankaj, for summarizing. And we have few questions before we close the session. And one question which I would like to ask Chitra. Chitra, you are a bedside nurse in a newborn care unit. Give me 4 or 5 bullet points as a nurse which need to be stressed that yes, you would take care when you are on duty, and you would tell the other nurses also to take care to address the concern of developmental supportive care for these small babies.
One thing I would like to do is we nurse all the babies in a oval boundary nest like boundary.
So nesting is one.
Yes. Then we make sure that all the activities are done at a single time, that is clustering of activities and minimal handling as possible. And we also fix timings, at least for extremely small babies, we touch the baby only 4 times a day. So we put a label on the bedside so that everyone will know the touch timings, and they'll only the assigned nurse and the doctor is supposed to touch the baby.
Right.
That is something we
So avoid unnecessary stimulation,
Yes.
clustering, club the activities, give them day-night cycling, and give them a good nesting, just
Yes.
like in utero position. Thank you for that, Chitra. And Suman, I would like to ask you one question, and the question is that 2 or 3 bullet points what you do to address pain. So Dr. Pankaj did talk about the pharmacological and the non-pharmacological measures. Now you see a baby, and what are the preventive steps you would take that you should avoid pain in this baby?
So while caring for the babies in neonatal ICU, always before handling the baby, always warm up your hands before touching the baby, and temperature variation should be minimized, and observe the behavioral cues of the baby, and before doing any procedure, observe the behavioral cues and identify them, and do the containment swaddling for the baby, and if necessary take all the non-pharmacological measures, and if required then pharmacological measures can be taken to minimize the pain.
Great, Suman. So that means that it is very important for the bedside nurse to be aware, to recognize that yes, baby is in pain, and then address these issues. Yes. So 2 interesting questions have come up, and Tanu, if you can answer this for us. So why is sleep important? Why do we always say that allow the preterm babies to sleep as much as they can? So why is sleep so important for preterm? Tanu, are you around? Can you answer this for us?
Yeah. Is my voice is audible?
Yes, Tanu. Please go ahead.
Okay. Oh, thank you, ma'am. So this is very important question because sleep helps in maintaining the circadian rhythm.
Yes, so the more they sleep, the better they will grow. It helps in maintaining the normal circadian rhythm. So it's very important for preterm babies to sleep because that will actually promote growth. That will actually promote them maintaining their normal circadian rhythm. Thanks for that, Tanu. And Dr. Pratima, so a baby is crying because of pain, or a baby is crying because the baby is hungry. How would you recognize bedside?
See, these questions are coming up again and again. How to recognize whether the cry is because of hunger, whether there are hiccups, which may be a normal physiological hiccup, whether the sneezing is a normal sneezing or a variant, normal physiological variant. So always remember, see the baby as a whole. How is the baby? Is he on any IV fluids? Was any sampling done recently? Has the baby been subjected to any transfer from one incubator to another warmer? So always look at the context. If the context says that there has been an intervention which has occurred, or you are going to plan an intervention, that indicates that the baby may be in stress. Otherwise, the only definite way to actually distinguish is to give the baby feed, and then if the baby gets consoled or is calmed down, definitely it is because of the hunger cry. And the other things, hiccups and sneezings, those also should be looked at in a wholesome contextual way. Normally, hiccups can occur, but if the situation was like if the baby is on IV fluids and he has an IV cannula, if he has been handled recently, just look for the regions where the stress or where the pain may be occurring, because of which the baby may be having consistent hiccups, persistent hiccups. So that would be the answer as per me. Dr. Anu, would you like to add?
Yeah, so the context is very important. What we understand is that baby by the side of the mother, just having breastfed, having hiccups off and on, reassure the mother. These may be physiological. There is no need to worry about it. Just fed. Vis-a-vis a baby is in the NICU, Dr. Pratima just said, has been recently handled, has an IV line in situ, you suspect some extravasation, or maybe just has passed stool and maybe in stress because the baby is wet. So context is very important, is one thing which would be the take-home message for this answer. So baby under phototherapy, and Dr. Purva, I would like you to answer this question. How do you, because these babies will keep on howling. So mother says, I cannot give phototherapy, baby seems to be in pain, baby is irritable. So how do you handle such a baby? Baby under phototherapy and depicting pain signs. Dr. Purva?
So most of the time what happens that such babies who are just there for the phototherapy, mother is also under stress. So we have to counsel the mother that this phototherapy is a requirement for the baby and this is a treatment. So we should be very much keen to also counsel the mother, because the stress of the mother also translates towards the stress of the baby. And along with that, what we can do is we can make the baby comfortable by just putting like two folded sheets on the sides of the baby. This will act a bit like a nesting, because we can do the perfect nesting, because this might hamper in the phototherapy area exposed of the baby in phototherapy. Also, what we can do, we can also contain the baby for a while, and we can ask the mother to stand by the side of the baby for some time, and containment can be done so that the baby will feel that the mother, like the baby is, mother is there to calm the baby. Now, these are certain things which we can do, and initially in the initial hours only this can happen for 1 or 2 hours or for a few minutes. Then the baby, and also should look after the hunger of the baby. Like the baby is hungry, and we should immediately feed the baby, because then if the baby is kept hungry for quite a lot of time, and that also becomes a stress, and the baby can keep on crying. So attend to the hunger, attend to the wet diapers, and then baby will be calm in the phototherapy also. Thank you.
So much, Dr. Purva. So baby could be hungry, baby could have a wet diaper, and that might be the source of irritability, not only phototherapy lights. So address these issues, tell the mother to give breastfeeding, and things should be resolved. So with that, I would over to you, Dr. Pratima. You can summarize. And lastly, I would, after Dr. Pratima has summarized few key points, maybe we have missed something, I would give over the final thing to Dr. Lalan. Sir has joined us online. Dr. Lalan. Okay, so my team informs me that sir has probably left now. So Pratima, over to you. You can summarize and then we can close the session.
So over the week and today also, we have learned 3 or 4 key messages I would like to give to the participants. Simple measures like breastfeeding, touching, swaddling, nesting, which require less time and less effort, will be going a long way. Not only for short-term benefits like relieving of pain and stress in the baby, but also for the brain growth. We should remember that any pain and any prolonged stress can have adverse outcome on the developing brain. Preterm itself is a stressful event for the mother and the baby, and moreover, if we provide stressful environment outside also, it will affect the brain growth. So for long term development and good outcomes, we should make our NICU friendly, development friendly, and rest of it has been summarized by Dr. Pankaj and Dr. Purva beautifully.
Okay, so I think Dr. Lalan has left. So thank you from the entire team to the team lead in week 4, and I would like to take their names again. So thank you so much, Dr. Purva, Dr. Pankaj, Dr. Tanushri, Suman and Chitra to join us live in this session. And heartfelt thanks also to Dr. Anita, who unfortunately could not join, and Miss Madhu. And thank you to all the participants who have joined us live today. And if there are more questions, we are open for questions till we end the week, and we start with a new week on Monday. And tomorrow you will have your MCQs loaded, and those of all who have not been able to attempt the previous week also, please go ahead and attempt this week at least, so that there is always a new learning when you attempt MCQs. You ask questions, so there is always bi-directional learning. So both for your benefit and for the other participants, ask questions in the forum. Our faculty will be more than happy to answer. Thank you once again.
Thank you, madam. Thank you. Thank you.